So just today I'll be talking about versatility of endoscopic spine techniques for degenerative lumbar spinal conditions. I'm very thankful for the organizers for inviting me to share my topic. Introduction of myself, I'm from Singapore. I practice in Ng Teng Fong General Hospital, which is part of the National University Health System. We look after about 12% of Singapore population. I'm subspecialized in endoscopic spine surgery. So I practice 80% of my elective load on endoscopic spine surgery. 50% of them are uniportal and 50% are biportal endoscopy. I do the full range of cervical, thoracic, lumbar cases with the scope. The history of endoscopic surgery actually started in 1986 when Pavis Kambin and Hijikata subsequently described the Kambin's triangle, which let us understand where is the safety of introducing sharp equipment. And subsequently, as the optical lens get better, and with the instruments, Anthony Young came out with the uniportal transforaminal technique. Over the early 2000s, a few people such as Sebastian Rutten, as well as from the Koreans, as well as Dr. Young, they developed into the interlaminar technique, and then it now evolved into stenosis, decompression, fusion, as well as cervical thoracic technique. Overall, uniportal spinal surgery have evolved into many techniques. For the lumbar surgery, in the limitation of time today, we discuss lumbar spine surgery. We have a transforaminal technique, which essentially comes from the side. Over here, can you see my annotation? Maybe I can draw. It's over here. This is the from the transforaminal window. And can you all see my arrow as well, just in case?
Yes, we can see that.
And then we have the interlaminar window, which is essentially what we practice in the traditional surgery. And because of the endoscope being a very thin, about 8 mm outer diameter scope, we can actually do contralateral approach all the way out to extraforaminal region. We call it the interlaminar contralateral endoscopic lumbar foraminotomy. We also can do in paraspinal approach, which is it's kind of like between the Wilsey and the Ray approach. And we can do fusion biportal from the XT leaf, which is almost close to where the Kambin region. So with the endoscope, which is small and mobile, we can have multiple areas that we can target in lumbar spine. So for example, this patient has a lumbar spinal stenosis, lateral recessed stenosis, and a foraminal stenosis, as well as extraforaminal stenosis. We can either target it through the interlaminar approach, which we can actually assess the ipsilateral lateral recess, contralateral lateral recess, as well as we can do a contralateral approach, which can assess all the way out to the foramen. So in this setting, a transforaminal, the interlaminar contralateral approach can substitute two surgery. One is an interlaminar approach and a transforaminal approach. We can save it for one single surgery, which is called contralateral approach. So for fusion approaches, there are many techniques as well. Generally, in the uniportal and biportal literature, there is an interlaminar approach, a Kambin triangle transforaminal approach, and somewhere in between, which we call endothelial, biportal and uniportal facet sacrificing posterior lateral approach. So there are three approaches to fusion. For the first two, the interlaminar as well as transkambin, when we do not take out the facet joint, we tend to use expandable cage or smaller cages. When we take out the facet joint, sacrifice the facet joint, we can put in large cages, T-leaf cages as well as O-leaf cages. So in uniportal, the main idea is there is a steep learning curve because we use different types of angle of scope, a 30-degree angle for transforaminal scope, and a 15 to 20 degrees angle for interlaminar scope. They have differences in the diameter, outer diameter as well. And then as we get a larger working channel and larger outer diameter, we can put in more efficient equipment. So in biportal endoscopy, however, they come from different sets of beginning. Osman and Soliman, they first described biportal endoscopy, and then the Koreans, subsequently now the Chinese as well, has written many articles on this technique. The biportal endoscopic surgery, however, started mainly in the 2000s. So uniportal surgery started first. The good advantage is that they separate the working portal from the viewing portal. So unlike uniportal, where everything comes through one hole, biportal can come through two holes or multiple holes. You can make separate even a third portal or fourth portal to achieve the decompression. So there are so many approaches, so many techniques. How do we get a grip on it? I think the first decision we have to make whether this condition is suitable for minimally invasive surgery or in particular endoscopy. In my mind, I wrote an article on this as well. There are red flag conditions that's not suitable for this surgery, such as fracture, infection of multiple levels, tumor instability, or neurology. I think neurology is a relative contraindication. However, dense neurology with power 0, you have to consider whether you should do a formal open decompression. And then in terms of deformity, that's more than 30 degrees. Sometimes I think you need a more open surgery for facet releases as well as maybe osteotomy. The second question is, what stage of learning curve am I at? I think in general, I also wrote another paper on this technique and endoscopic ladder of competency. If we are just doing discectomy in most of our practice, it will be challenging to list a case for fusion. You may take many hours and it discourages people in your hospital as well as yourself in continuing the journey. I think it's good to do a gradual increment of your technique, and hence you are suitable for the quaternary ladder of endoscopic techniques such as anterior endoscopic cervical discectomy, fusion, revision fusion, and contralateral approaches, which is kind of a more difficult technique. Then second thing is whether we should do uniportal or biportal. I think that discussion is between really your expert opinion on which surgical technique that you are comfortable with. Uniportal, being least invasive, can be done under local anesthesia and sedation in the transforaminal approach and selected interlaminar approach. But you really focus on docking directly on target and work on the area of operation. And you need modified advanced technique if area of operation is too wide and is too far from docking. For example, if you dock on the wrong area in uniportal surgery, sometimes it's very, very difficult because of difficult angulation, that you cannot achieve the adequate decompression if you dock on the wrong place. Biportal, however, has the advantage that even if your docking is slightly off, being a floating technique, being more like a outside-in approach, you can actually still complete your decompression if your docking is not of the correct area. However, of course, biportal, just like any of the MIS surgery, it shouldn't be docked too far off the area of operation. And you can introduce larger equipment in biportal surgery. For example, a large osteotome, a large size drill, and large size forceps. And hence, you can do O-leaf cages through biportal fusion. So this, due to time limitation, I basically show some more interesting cases and also touch on endoscopic fusion as the 4th generation of spinal endoscopy. First case is done using unilateral bipolar endoscopy in interlaminar technique for adjacent segment degeneration. This is a 77 years old Malay lady who had a previous L3 to S1 fusion more than 10 years ago. And for the past year, having increasing bilateral leg pain that radiate to the bilateral calf. Typical neurogenic claudication with 10 minutes of claudication time. Neurology is unremarkable. You can see that there is adjacent segment degeneration over the lumbar 2-3 area. This lumbar 2-3 area is traditionally a difficult area to decompress because of the narrow interlaminar window and the very steep angle of the facet joint. There is a chance of compromising the violating the facet joint if we do a wide open laminectomy. How about fusion? This patient is 77 years old with questionable bone quality. Her BMD is really low, it's -4. Fusion of adjacent segment may have more problems. So we decided to do a UBE decompression. So I have written my chapter in this textbook on this technique. These are the various techniques. So this typically I use the best set, which is from Korea, and then we have a sweat stem. There are various endoscopic drips as well. And then we typically use a shaver or burr. I start with a cutting burr, and then I change to a diamond burr. We need to use radio frequency ablation. I think I use there are various company, but I use Bones, which is from China. And then we have the arthroscopic system, as well as fluoroscopy and saline bags. I think that there are two components of energy. One is the plasma coagulation, which looks like your shoulder and knee surgery. However, have a lower energy suitable for spine. It's good for work that's outside the flavum, typically stopping bleeding in the bone. And then then there's another radio frequency ablator, which is smaller in nature and touch on close to the nerve roots and stop epidural bleeding. The docking area is I used to do UBE more, although BESS is another method, as you can read in the literature. UBE typically is about 2 to 3 cm apart, 3 cm apart from the two working portal. In the left-hand side, viewing portal is here, holding with your left hand, and the working portal is underneath, or just next to the L5, medial to the L5 facet pedicle, medial to the L5 pedicle in the L4-5 decompression. We aim for the spinal laminar junction, and then so we can dock there. This is the video showing how it's done. This is the video of the docking. So you can mark the spinal laminar junction, and then this is the needle placement, and we dock at the spinal laminar area. This is how we decompress, and essentially you can see from the nerve hook that we have adequate ipsilateral and contralateral decompression. I start from the ipsilateral side with the cutting burr, and burr on the spinal laminar at this moment of time. It's important to create a sufficient working space, and then you can get on to decompress your ipsilateral and contralateral facet. Because of the endoscope good view and directly in front of the endoscope rather than at the microscope at the file at about 50 cm away from the incision, we can actually have a very limited amount of facet resection to achieve decompression. So as you can see, this is a 4 mm diamond burr now. We typically shave about 3 to 4 mm of the facet joint, and that's sufficient for decompression. We can now see the caudal lamina of L3, and you can see the head is on the left. The ipsilateral side is on the bottom at 6 o'clock position. Now we drill on the L3 caudal lamina, and then we reach the contralateral side. Now I'm doing the spinal laminar area. We create a sufficient space, and now you can see the facet joint opposite. There's typically a cleft between the two flavum. You can use the Penfield or Curex and then separate them, and you can take out the flavum either piecemeal or as an en bloc. Those cases when the flavum is not so so stuck to the dura, they can be taken out on block. For this case, I think this patient is a revision, kind of a revision surgery. So we actually have some dura adhesion. So I take them out in a piecemeal fashion. Ipsilateral side first, then the contralateral side. When I lift up the flavum, if I see that the dura is stuck, when the dura also get lifted up, I will use some radio frequency ablation or pen field to slowly separate out before I take out the flavum. Now we can see we can use a hockey stick chisel and very meticulously chisel off just a couple of of the contralateral superior articular process. You can see that the large part of the superior articular process still preserved. However, the spine nerve roots are fully decompressed. And this is the patient immediately after surgery in the same day, post-op day 1. I finished this case at 6 p.m. So I saw her next morning and she's walking very well. This is how she described her feeling. And then she said that she's walking well, and then there's no pain. This is the wound. Basically, I incorporated my incision into her old wound. So she has no new additional wound despite having another level of decompression. So this second case is interesting. This patient comes in with a cauda equina syndrome. 43-year-old, 1 month history of lower back pain. However, suddenly she sneezed heavily and then developed perineal numbness and urinary incontinence. And then she woke up being unable to, she wet her pants and have no urge in passing urine. She has, at the point of time, no bowel incontinence. Interestingly, she has no pain, but anal tone is lax. So this her X-ray is really unremarkable. MRI shows a huge prolapsed disc. This one I chose to do uniportal endoscopy. I start with a stenosis endoscopy, lumbar, and I start on the left side. The top of the screen is the head. The right side of the, the left side of the screen is the head. The right side of the screen is the foot. And then I'm standing, the bottom of the screen, 6 o'clock, is the left side. So I do a laminotomy now. I started out with a larger 4.5 mm diamond burr. Then I switched to a 3.5 mm diamond burr. And then I did a flavectomy. As you can see here, I use an endoscopic pen field to lift up the flavum to be less traumatic. And then they lifted up on block. In this case, it's acute, so lifting up on block as one piece is not too difficult. So you can now see the dura is in a lot of tension, and you can immediately, under endoscopic vision, see the prolapsed disc. So we managed to retrieve this disc as well as all the fragment without actually need any significant maneuver of the dura. So it's very important in dura that in nerve root that are compromised already. There's neurology already that you do not manipulate too much by any further retraction, which may further compromise the highly compromised nerve root. So in this case, I use the Garrison to tease out the fragment carefully and then retrieve the fragment. So this is the large fragment that is causing her the cauda equina syndrome. And you can see from the next video that after we decompress, I switch to a smaller scope, the interlaminar endoscope, and you can go to the ipsilateral and the contralateral sides, and we are assured that it is decompressed. For this extended indication, the large sequestrated disc of prolapsed dissection, you can see that she walked very well. It took her a while. The cauda equina took her about 6 months to resolve. Now she pee independently. And this is the post-op MRI. You can see that fully decompressed. This is the wound that she has. And we have seen her for a year. And this is the MRI pre and post-op. You can see that there's a large sequestrated disc. She took a while before she recovered. However, you can see from the MRI post-op, which is at the bottom, that the caudal equina has largely resolved. So this endoscopy, I tend to do discogram to light up the disc in blue. It helps to identify the disc well under the nerve roots, and then I did a LE/ULBD first, the decompression, and then I switched to a smaller scope to make sure I clear up all the discs, and you can see that most of the disc is removed, and there's adequate capacious spine epidural space. The next case is again adjacent segment disease, previous L4-5 fusion. However, the adjacent segment is not the L3-4, it's actually L2-3. The patient presented with severe pain on the right side, radicular pain, he's unable to get up. In fact, he was hospitalized for that. And then we find that he has a large prolapsed disc at the L2-3 region. And L3-4 looks okay. So I asked my options for my colleagues. A lot of them asked us to basically extend the fusion, so do L2 to L5 fusion. But my choice is just for this elderly gentleman is a transforaminal scope. It's done under local anesthesia. And we started with the transforaminal endoscopy. You can take out the disc from the side, as you can see here. The docking of the L3-4 region, L2-3 region is 6 cm off midline. You can't go too far off because kidney is nearby. And then the view that we can get, this is again tied up with indigo cami. You can see very clearly pulsating nerve root after we take out the prolapsed disc. You can see a disc fragment here. Lifting up the disc fragment, you can use a nerve hook or endoscopic pen field. And that's when we retrieve the fragment, and then we can see a pulsating nerve root. Tend to have, you can see all the way to a contralateral side, and then that's the PLL, that's the contralateral side. So that's significantly decompressed already. I think there's still a ligamentum flavum hypertrophy. So I did a lumbar endoscopic unilateral decompression, bilateral unilateral laminotomy, bilateral decompression. Again, L2-3 is a tight area. You need to create space first. This is the right side. I'm on the right side, so you can see that the head is on this area on your right, and then the bottom is the foot, and the 6 o'clock position is the right side. So we did ipsilateral laminotomy first, and then we go contralaterally now, removing the flavum. I find that the uniportal scope is as efficient in my own series, which is data is going to be submitted for currently a European Spine Journal. I find that both the uniportal and biportal have similar good results in the trial that we did in my hospital. So you can see that we have now decompressed, and when you are decompressed distal enough, they may have a gush of blood because of the crossing vein next to the nerve root. And usually there's a good sign. However, in uniportal scope, sometimes it can cause a lot of difficulty in visualization. We can bump up the pressure up to 70 mmHg for a short period of time. I generally recommend 25 to 30 mmHg. Mercury for most of this part of the surgery. So we use flow seal to stop bleeding, and this fragment removed, and that's the flavum removed. The patient, this is the incision that we make. Surgery took about one hour and 10 minutes, about 1 hour 20 minutes. The patient was discharged the next day. This is how he walked. He was initially bedbound, unable to walk. So he's quite happy. I've seen him now 2 years, and he's currently retired for his own reason, but he's happy with the results. Okay, so this is a 1 year post-op. You can't hear the video, but he's doing well, and this is the wound. So the next one is the revision transforaminal. This patient had a endoscopic surgery done by my colleague. Pain not better after decompression. The L45 still having a foraminal stenosis in the disc. So I use a biportal to revise her. I think the uniportal revision is as good, but I tend to revise far lateral approach with biportal surgery. So to give you good visualization, is a left L45. So you can see the superior articular process here. Actually, it looks very similar to uniportal surgery, just that it's, you can use larger equipment. Sorry, the video not working very well, but essentially we went on to do the. So I think the video is not working, but we went on to decompress the spine and she did well after the surgery. I think this is the next video. You can see that it chopped the superior articular process off. You can see the traversing nerve root right inside here. The lateral aspect of the facet are preserved, so they support and prevent instability. We just take out the tip of the superior articular process, so it doesn't affect stability. And then exiting nerve root is right here. You can see that. So you can see the traversing nerve root, exiting nerve roots, and then with the decompression, we use a very curved curex, and then just to clear up the foraminal ligament next to the traversing nerve root. Now we clear up the disc. There's some bulging disc next to the nerve roots. We are performing now foraminal discectomy. You can see the facet joint here. So this is foraminal, and then extraforaminal is at this region. Actually, they can be assessed quite well with the endoscopy. So this is the disc that's removed. This is the wound, and this is her video. 2 weeks post-op. This 2 weeks post-op wound, and it healed very nicely. Yeah, she feels stronger, she's saying, and then she feels that she walks better. They are both they are day surgery in my series. So I publish about endoscopic fusion. These are various publications in both uniportal and biportal fusion. I do a mixture of both fusion for academic purposes. I think both are equally giving good results. I think there are many ways of doing fusion. Most common practice way is the transcambin fusion, which is use the transforaminal scope, the 30-degree small scope, and we use special retractors as well as the small cage. This is published in the International Journal of Spine Surgery with my colleagues. So overall, we need some special retractor, and then we can get through the corridor and the Cambin triangle, enlarge it, and then provide fusion. So we tend to use endoscopic drill to do the disc preparation and special curette to do the disc preparation. Several companies makes this, and then eventually through the indirect decompression, put in a cage that expands. This is another type of fusion that I do, which is posterolateral fusion, a much wider fusion. You can see by sacrificing the facet joint. So we take out the entire facet joint, just like T-leaf in MIS surgery, and then we can put in large cages. These are the intraoperative video and photo. Also, we published this technique, and we describe Wu's point and Kim's point under me and my mentor's name, and start from the spinal laminar junction and work outside to resect the entire facet joint. We find that from the outside in technique, where we start from Kim's point working inwards, is actually faster than the inside out technique. So this published in these 2 articles about the technique as well, just to highlight how it's done. So we dock, this is the inside out technique. So we dock at the spinal laminar junction, and this highlighted through the X-ray. You can see the superior articular process. And then we dock, start working on the superior articular process, and then drill out the facet joints, both, and retrieve them as autograft, and then we through a large retractor, working cannula, we can put in a large T-leaf cage, and then you can see the entire facet is removed, and the screws are put in. This is a video showing how it's done. It's done 2 years ago. 57-year-old man, spondylolisthesis, typical claudication history in L45. So we start with lateral recess stenosis, foraminal stenosis on the L45 on the left side. So we do a left L45 endothelium. These are the pictures that we showed you before. Ipsilateral side is at the bottom. The head is over on the at this area, 9 o'clock position. We start doing an inferior facetectomy, and then lift up. We drew a bit of the joint to separate it, and then we can retrieve the inferior articular process through, as you can see here, as an autograft. And then you can see the ligamentum flavum as well. You can remove the superficial part, and then you can then now remove the entire flavum after you do the superior articular facet resection. You can see some of the superior articular process here. So I use Harrison punch so that we can retrieve bone graft after you remove sufficient space of superior articular process. You can use the working cannula to protect the traversing nerve root. Then you can subsequently do the disc preparation. This is a uniportal scope, so you tend to use the drill a lot more. The radio plasma coagulator a lot more, and use the pen fill to prepare the disc space. After you prepare the disc space, you can see that it's well prepared. As you can see here, I hasten up a bit of the video, and then we insert the cage under fluoroscopic and endoscopic guidance. And this is how the cage look like after the when we finish. Then we put in the pedicle screw, and the surgery is over. Biportal posterolateral fusion is quite similar. It's an L45 biportal fusion, very typical, similar history. Left L45, foraminal stenosis, and then central canal stenosis. This is how we position them. We position them on a pro-axis table. I flex them first, and then subsequently, after placement of screw and decompression and cage in, I extend them back to neutral. It's a video of showing how we dock. Basically, we dock at the spinal laminar junction, which is quite similar to uniportal fusion surgery as well as the posterolateral aspect. We clear up we identify the spinal laminar junction, and then we perform endoscopic drilling to mark it. A lot of the facet joints resected through the osteotome so that we can retrieve sufficient amount of autograft. So you can see we are doing radio frequency ablation on the spinal laminar junction and exposure in the laminar space. This marking is basically an X-ray marking, just to tell me where I am, so that you can see. And then I use the osteotome and cut across, according to my article, Wu's point to Kim's point. This is how we cut it using an osteotome. You can see we mark the Wu's point to Kim's point, and then we just osteotome it. It's safe because the superior articular process will protect the nerve roots. And you can have large amount of facets for autograft purposes. You may consider cutting them into smaller pieces so that it's easier to retrieve. You may want to cut into about 3 pieces rather than 1 piece. A larger piece, although it's easy to cut, but sometimes hard to take out. And then after that, you can exposure of the ligamentum flavum. Then we can work on the superior articular processes. And then now we went on to do the contralateral decompression. You can see we can decompress all the way to the contralateral side. Over the top decompression. And then just finishing up the ipsilateral side as well. Taking out the superior articular process, exposing the rest of the disc. It's just a foraminal ligament, the last bits of the ligament before we can expose the disc and perform fusion. using a curette, you can remove a lot of the flavor. And then now you can see the traversing nerve root very clearly, the bulging disc, or in the spondylolisthesis case, stop the bleeding. Okay, and then you are good to go to prepare for the disc. So this is how we prepare the disc. We start with dilator. These dilators are what we use in traditional surgery. It's no difference. Any company's dilator is good enough. Of course, there are some endoscopic company that makes a specialized dilator for endoscopy. I think it's easier, but I think if it's not available, any dilator is good. So we prepare the end plate with dilator using a radio frequency ablation as well as endoscopic pen fill or curettes. You can use anything that you are comfortable with. And then this is how we trowel the cage after we perform the decompression, remove the ligament, the disc. You can see the end plates quite well after we remove the disc and lift them up as a piece. I think this endoscopic surgery have this superior visualization of end plate. We make sure we don't violate it. We can understand it, and then we know where to put the cage is the best for the patient. I think it might be a little bit more difficult to use the microscope to get this view because of the obstruction by the bleeding. So we can really see that majority of the end plate is prepared, and then we do a final trial of insertion of the cage. So you can see the cage after we inserted. It's next to the nerve roots. And then we put in pedicle screws, just as per usual. It's the wound, and it's published. Our paper is open access journal, so you can see the technique. In conclusion, there are many techniques in endoscopy, spinal endoscopy. I think today I just cover some of the interesting cases. The decision on correct target is important. You should know your technique well, and then which weapon or rather which scope that you are comfortable using. If you are doing uniportal or biportal, you should dock at the proper area so that you can minimize soft tissue damages, which is the principle of why we do endoscopy. With the clear visualization of the lens and the good water pressure, you can ensure a comfortable surgery for both you and the patient, and use the suitable tool for working channel. Use a larger drill if you need a lot of bone work. Use a smaller drill if you want to preserve the facet joint. And then try to minimize the collateral damage and yet take out the target to benefit the patient. Thank you very much.
Thank you very much. Okay. Thank you very much, Dr. Wu, for your wonderful presentation. And thanks, we actually know that you are come from China, right? You are originally from China, and you speak very good Mandarin and Cantonese. And thanks, Dr. Thomas have that. So so can we just talk later in Chinese so we get understanding? Okay.
Yeah, or I can speak Chinese, Cantonese, English, okay. Whichever you're all comfortable. My dad is Guangzhou, 我爸爸係廣州人，所以then I migrated to Hong Kong, and then now I came to Singapore when I was very young.
Okay, that's great. So 我们后面就用中文来讨论，可以吗？这样的话我们
没问题。
大家听了那个吴教授的这个讲课之后有什么问题，可以跟他讨论一下，用中文就行。
对，问一下吴教授，UBE 是吧 ？UBE 对，他是 UBE 啊，他讲的是 UBE 跟那个对于这种滑脱的病人，这个 UBE 就是一度滑脱的话，他可以做 UBE， 这个是大家都公认的。对于二度滑脱，像这种可以做 UBE， 这是第一个问题。第二个问题就是 UBE 的话，这个融合率怎么样？因为我们也做过 UBE， 就做过不多，但是也是今年才开始做。谢谢。
所以在一度滑脱跟双度滑脱、二度滑脱我们要了解一样东西，那个二度滑脱是因为它是很 rigid 很僵硬，没办法自动回去，就做 extension firm 的时候，它能回去比较好的变成一度滑脱嘛。如果它很 flexible 的话，那 UBE 技术是可以做我本身有做过二度滑脱的。那如果它不是很flexible 的话，你可以用两种方案。第一种方案是你要做多一个 incision， 就做一个contralateral， 就是对侧的减压，对侧的 osteotomy， 就是在你做自己本身 ipsilateral side 的 osteotomy 之前，你就要做对面的 osteotomy， 那需要另外一个incision。一个小小的中间的两个双通道 incision 去做那个东西，才做那个 release of the opposite 的那个 facet joint， 就是对称的关节突的那个 osteotomy。做完之后才回来做等可以打钉子把它拉回，然后做拉回 grade 1， 然后做 ipsilateral side 的。那当然，如果相对来说很困难的话，那做 open surgery 也是不错啦。因为我们要考量到做内视镜手术也不要做太久，所以如果那个手术需要很长时间，那我们的个 minimally invasive 就是微创的技术的那个宗旨是为了什么？就是为了病人舒服嘛。那如果做太久就不舒服啦，那不如做传统手术。所以通常如果经验足做很多grade 1的话，然后就可以做一些 grade 2。不过我发现啦，其实做 open 也好做 scope 也好，它那个 grade 2很多时候你打完钉子放一个很美的融合器，它自然会慢慢滑，从0也会慢慢滑到1的啦。不过很多时候不会滑到 grade 2啦。因为最重要是那个 bone quality 跟那个钉子最弓紧螺钉子多过于那个 end plate preparation， 我是这样觉得。那如果是grade 2的话，有时候你融合器就不一定放得很大，除非你把它好好的 reduce 成 grade 1还是 grade 0。然后第二个观点就是融合嘛，第二个问题是融合的情况如何？我们做的1年跟2年的数据是挺好的。其实我的单通道融合手术的1年 CT data 已经 published 在 Global Spine Journal， 所以不输于传统手术。那双通道的融合也有有一些韩国的朋友也是有 publish 这些 data 还不错。那当然我们没有 MIS 跟传统手术那么长的 data 啦。
就是我想请教一个问题我们所知道的，无论是单通道还是双通道都可以做一个单纯的减压跟血的摘除，也可以做一个镜射的融合。我想问的是，就是说判断一个病人是否需要融合的标准，你们是不是说看它的稳定性？如果是单纯看它稳定性的话，那判断稳定性的那个指标或者个量化标准到底有多少条？这2个问题我想问一下。
基本上融合跟减压手术在用单通道双通道的，其实那个 results 那个最后病人的效果还是挺好的，也是差不多，我觉得2个方法都可以是热肩手术。在我医院基本上90%的人都做热肩手术，不管是单还是双通道。那在考量融合还有减压这2方面啦。如果他的痛是多于腰痛多过脚痛，然后他在 转身还是在换姿势的时候非常疼痛的话，我通常会考量做融合手术。当然，做融合手术，不只是考量应不应该做，也要考量它的骨的素质的原因啦。如果是老人家，他的骨质疏松很差，然后打钉子还是融合器会感觉上效果就是不是很好的话，我还是建议做减压。所以很多时候超过75岁、80岁的，我们有时候都会考量减压啦。那减压我也有做相当多的这些80岁以上的人做减压。那减压如果它只是好像出口根，好像 L5 出口根压到，然后造成脚疼痛、屁股痛，还有好像 VAS 4到5的腰痛的话，我有时候会做减压。如果年纪大，那他们效果还不错，那个腰痛会从4、5的话会变成2、3这样。他们还是有时候需要吃一点止痛药，可是他的脚痛会，如果是6、7、8的话，可能会减少到2、3，还是更少都有。如果好处是我们不用担心那个螺钉怎么样，也不用就是他开心我们就开心，因为不用担心那个融合器最后怎么样，融不融合，钉子怎么样。所以这个最重要考量是最好做手术后我们睡得安稳，他们睡得安稳不用担心他那个融合器。所以我减压的手术还是比较融合的多。我觉得用内视镜做的话，你相对来说，多数内视镜做的医生都会减压比较多，因为很多时候，好像你看我刚才给你看的23啊、12啦，我下周也有一个12/1的 T12/1的减压手术，做内视镜没什么会让他们不稳，我做了挺多，也没有看到不稳的现象，很少。所以我还是挺敢做减压手术的。我希望我回答到你的问题，不懂有没有直接回答到你的问题
那吴教授，我也问一下您一个问题，就看你那个确实是作为我们那个单通道也好，双通道也好，是在做一个做得非常早，也做得非常好。就问一个技术的问题，我自己做双通道手术的时候，经常会遇到出血的控制会比较困难。就你在手术中，单通道我觉得还可以，双通道的手术血会控制比较困难。你有什么好的 tips 可以跟我们分享一下？你在术中控制这个双通道里面的出血吗？
在那个流血的状况是通常是可以预料中的事情，是在第一我们要了解它在哪里流血，如果是在拿出黄韧带前流血，通常是在特别有几个地方啦，就通常是下关节突跟上关节突内侧偏向，如果是左边的话偏向于差不多6、7点。如果你是那个椎关节，不如我 share screen 来跟你看一下，等一下哈。我们可能这个用那个图片会比较容易说。用那个 coronal cut， 等一下，找一个图片。找这个图片吧。这个下缘这里如果黄韧带还存在的话，这个下缘这里会有一个 articular artery 会流血在这里。如果我们如果烧的太远的话，烧到来这里肯定流血，而且很难止。因为难止是因为什么吗？我们的那个 portal 放的地方那个 angle 不是很好，那个角度不是很好，所以通常要用plasma coagulator 要很细心的止血。所以我建议不要把这边不要下去太远。 差不多看到关节，然后下一点点就可以，那可以避免这个浪费这个时间。第二，我们放 viewing portal 的时候如果我们是左边let's say 我们是左边放 viewing portal 的时候，观察内镜的时候这里不要刮那个骨头刮太上缘，刮上面的话，这边有一个 radicular artery， 也是会有一个叫 interarticular artery 这个也是经常流血所以你不刮上面也没事。那还有另外一个地方就是在如果你在 far lateral 这里，当然 between 那两个 transverse process 中间那个 membrane 过后会流血这里比较多。然后如果黄韧带拿出来后通常是黄韧带左边右边都有，这边有一个血管下面也是有一个相对来说有一个血管会流血这两个会流的特别多。那通常用 plasma coagulator 去把它调低一点，然后把它们烧掉先，才把它拿出来，会减少止血了。那拿完这个 flavum， 你如果减压减得好，通常在这边在那个行走跟要出 pedicle 之前，它会有一个 vein， 它有一个 crossing vein， 就是我们从外来进来的一个 crossing vein， 你会看到它会也是流血，那个需要用那个 radio frequency ablator 去止血。然后下一个就是那个椎间盘椎间盘那边有一个像圆圈的一个环的那个止血需要止，那个也是用 low energy 的希望我能让你了解。那你讲双通道比较止血比较难，其实双通道跟单通道都一样，我反而觉得单通道如果你把黄韧带取出来后，需要加那个水压才可以看清楚，因为毕竟那个出来的血都是从那个单通道出来，就是在你的 lens 那个旁边的那个出口处出来，所以你会一直看到血喷在你的脸上，不是喷在你脸上，喷在你的 scope 上。那双通道它会从外面流出，如果双通道那个出口道那个 working portal 如果不是很流通的话，那可能会血流出去比较困难的话，会有比较多看不清楚的状况。就这样。
好的，非常感谢您讲的特别仔细。
各位还有没有什么机会难的？
大家有什么问题？
要看一下双通道的那个。
在广州还是相对来说比较多单通道还是双通道的医生呢？
在我们这边的话，先开始的是单通道的做的比较多，后来这2年双通道也慢慢的火热起来了。特别是单通道、双通道的话，它辅助融合，现在也越来越流行，都差不多。但是有些医院可能传统上面做单通道比较多，有些医院新兴的医院，他们比如说双通道做的比较多。因为我感觉双通道它的学习曲线相对比较短一些，很多在广州的骨科医生他们有这种关节镜的技术，所以他们掌握双通道的时候呢，相对比较快。还有那个吴教授，我刚才再请教你一个问题吧。我看你有一个病例里面你是用双通道去做这个极外侧的versatility lumbar distal 的极外侧椎间盘突出。那我个人的感觉，如果是极外侧椎间盘突出用单孔镜去做，会不会更好一些？因为你不用去切掉这些女性的结构，就可以直接到达那个突出的椎间盘的外侧。那您是怎么考虑这个手术单通道还是双通道的呢？
那我2种都有做，那第一要看它的 foraminal stenosis 有多严重如果 foraminal stenosis 很严重的话，单通道要有7毫米外径如果直接压下去会有相当多的病人可能不是就有20-30%吧，有可能会有一些 extended nerve root 的不是很合适 extended nerve root 的 dysesthesia 就会有点麻。那这个我们用双通道的话会相对来说比较少这个问题，因为是 floating technique， 就是一直都看着那个 出口根来做这个手术。那第二点就是看你要切多少骨啦，如果很多骨要切的话，就是上关节突前侧的地方，如果真的很肥厚哦，很多骨要切，那用 chisel 还是 osteodome 还是比较快啦，我是觉得。当然我也有publish 也有写那个 transform 那种用 drill 的方法来做这个手术也是可以，也不是很久，可是我比较喜欢有时候用 osteodome 来处理这些比较多骨头要拿的东西，拿的病例。然后第三就是这个 revision 嘛，就是复修手术，可能我刚才没有说仔细，它是复修手术，它以前已经做过 transforminal 了。那在复修手术，我还是比较喜欢用双通道，因为看的比较透彻一点，因为没有这么 magnify 啦。如果单通道通常要比较就放大更多，比双通道放大多。双通道你也可以很放大，你可以放进去放出来。而单通道为了止血嘛，还是为了retraction 方面，你还是得比较靠近啊，才能把这个手术做透彻。所以在复修手术通常我很多时候都是用双通道做啦。那如果是第一次手术，当然会做单通道也是不错，只要选得好还可以。如果单通道的话，我们通常会加一点类固醇跟那个 Marcaine 来防止那个 extending nerve root 的痛啦，出口根的痛。我是这样觉得。那个双通道我也是有放啦，其实双通道也是有放，可是相对来说我觉得比较少痛。基本上我做 far lateral 好像没有几个病例会有 extending nerve root 的那个 dysesthesia， 可是我做单通道时不时都会有。所以讲微创嘛，这个我现在对微创的观点有一点，做了2个通道后有点不一样，就是微创就是病人起来非常快乐就是微创了，所以不用为了1个洞2个洞而纠结啦，真的。
好，那非常谢谢吴教授。
来问一下这个吴教授，T-Leaf 的这个 UB1 在 UB1 相比较的话 ，UB 有哪些优势呢
？UB1 的 T-Leaf 的优势吗？如果你是讲 MI 对 tubular 还是对单通道啊？Miss T-Leaf 就是 tubular 还是就是 tubular versus biportal 啦。那其实2个都是很好的手术 ，Miss T-Leaf 的那个历史比较悠久然后很多医生比较熟悉那个手术。所以相对来说比较利索，而且做的比较有效率。biportal 的手术 fusion， 如果我们做的多的话，也是挺快的，也是挺有效率的。我觉得最好的是它的 disc preparation。第一，我们可以在很短时间内把那个上下关节突切除啦，因为基本上有生盐水，然后直接就插到那个下关节突了嘛，所以通常在5分钟内就在开始切那个下关节突啦。那上关节突也是很快就可以切除掉。我们花很多时间在那个 disc preparation， 可是是好的，因为那个椎间盘切除这个要切除的透彻才会好好融合嘛。那 MIS T-Leaf 的就是比较远，然后那个 microscope 就是比较远，它就基本上是看不到。我本身我不知道，可能你们国内专家比较有经验的可以看得到，可是我本身觉得用 microscope 比较难看到那个 end plate 那个有没有切除的好。通常我们拿一个 shaver 还是拿一个 pen feel 来感觉凭感觉来知道 end plate 有没有prepare 的好。可是内视镜就不一样，你可以直接看哪里还没有做完就可以把它做完。那做哪里弄了一个 骨头如果磨损了，我们就避免放那个 cage 放在那边，可以有那个观点。所以我觉得那方面内视镜融合还是有相当的优势。而且本身内视镜嘛，你就不用切一个圆圈，把那个圆圈里面的肌肉都切除，基本上放进去就在那个肌肉上面，就在骨头上面切除相当少的肌肉，就可以把那个融合手术处理完。
教授，问一下，就是说双通道跟单通道，您都做了很长时间的熟练。如果就是比如说一个病例是单纯减压，那你更倾向于选择单通道还是双通道？第二个就是如果是一个镜下的需要融合，那你又是如何选择？第三个呢，就是说，这两种的时间，就是操作时间，这长短。
OK， 所以如果那个脊椎压力就是比较多骨头要做的话，我通常选择双通道啦。可是如果好像那个黄韧带比较肥厚，可是骨头不是很多，那我觉得单通道也挺好，因为直接就病人还是比较喜欢一个洞多过2个洞啦。所以时间方面其实因为可能经验嘛，我就知道哪一个会花比较多，要切比较多骨，就不会去做单通道。那其实2个变成时间都差不多是控制在1个小时到1个半小时内可以做完1层的手术。所以如果让我选，我2个都有做，就看他如果骨头多的还是做双通道比较好。如果不知道，没有什么，不是说不知道啦，如果没有这么多 imaging， 没有，因为病人没时间去，还是经济上不要做那么多 imaging 的话，那做双通道可能比较稳当一点不会花那么多长时间。那第二，你是说融合是吗？融合是2个相比来讲，如果多过1个 level， 我通常做双通道啦。不过我跟你讲，我的老师我的 Husong Kim 是我老师，他是韩国数一数二的单通道医生他做4个 level 也是很快。那真的是就看他的修炼啦。所以这也很难说，他可能做4个 level 比我做biportal 4个 level 快1倍都有可能，因为就他修炼到9成功力了嘛。不过如果给我选了一个 level 的话，其实差不远2个时间差不远。如果多2个 level 3个 level 我就想可能用 osteodome 快一点。那为什么还在做单通道融合呢？其实他的 result 也不错，病人也很开心，然后我也是在一个大学医院嘛，所以还是两个都要都做吧。那第3个问题是什么啊？我忘记了，说太多。
第3个
这2个。
我也忘了。
对。
两个，第二个、第3个连在一起的。
手术时间，我也回答了。基本上因为都得控制在1个到1个半小时内我本身是觉得我是很坚信那个微创的概念微创的概念就是第一不插尿管如果一个 level 的话不插尿管，不放cuff bump 然后尽快完成，安全的完成，尽量不要把它变成传统手术。以这个观点的话，你那个外科医生觉得哪一个比较适合就采取那个手术咯。我觉得单双通道我们已经有数据了，没差别，几次回家都没差别。
教授，我再问一个问题 就是你在比如说单通道是通道的时候，你的那个目标把它点上来，就你的主要的视野放在哪个位置？我刚刚看到你的 PPT 有2个图，好像你的点比较靠内一点点，然后有一个点是比较靠外，这个是什么意思？怎么选择呢
？OK， 所以我的那个dock 在哪里哈，靠在哪里？我有一个 paper 啦，那个12 steps to LEULBD 的，你们可以搜到。那我通常我跟我的老师Prof Kim 我们是比较喜欢做那个 OK 也可以看得到是在这个 point， 你看还在有 sharing 吗？还在有 share screen 吗？我再 share 多一次哈。在这个 point 我会到这个 point， 我们叫 laminal facet junction， 在这个 point。那我们是那个减压哈，减压是一个 sublaminar 的减压，就是我们内视镜是往下面看的，所以如果那个医生要 revise 我的手术，他会发现哦，上面的骨头基本上都还在，只有一点点不在，因为下面已经给我挖空了，可是上面还是存在的。因为我们从这里做上去的话，不需要刮很多骨。直接在 flavum 跟骨头前方做那个磨钻就好，也看得去侧面也看得挺好。这个点的话，看这边就会需要相当多的骨头减压啦，在这个地方要 drill 过去啊。另外一个方法也是我另外一个老师做的，就 spinal laminar junction， 就是 dock 在这里，这个也是比较多人用的方法啦。那他的观点不一样，他通常要 drill 这里把它 drill 的挺透彻到那个 flavum 差不多要 drop off 了，就是已经差不多没有了，那才开始减压。它减压下面是看下面是比较容易所以2个都可以，我觉得通常做这边如果 dock 这边的话，他们通常会很快就用那个 Carrison Ranger 来 endoscopic Carrison 来咬那个黄韧带。我们本身在这里开始的话，在这一个 laminal facet junction 开始的话，我们是磨钻到真的是没有骨头钻了，才用那个 pen fill 来把它减压。所以通常是 on block 一整块 flavum 拿出来的。所以2个我都有做啦，不过我比较喜欢做下一个方法，那个 laminal facet junction。
非常感谢你讲了这么多，我们同学学员们也真的是学了很多，非常感谢。
谢谢你们。